Thank you. And I will start by talking about the epidemiology of pneumococcal antibiotic resistance in this region, Asia Pacific. And we know that the antibiotic resistance rates of strep pneumonia is different in different countries. From the study of ENSOP in 1990s, the results show that the instance of antibiotics is higher in some countries, including Vietnam, Thailand, Korea, and Taiwan. And the antibiotic resistance rate is relatively low in India, Malaysia, Singapore, and Indonesia. We know that the major driving force for the emergence of antibiotic resistance is the use of antibiotics. So it means that in these countries, more antibiotics may be used, especially for pediatric patients. And usually, the antibiotic resistance rate of streptococcal pneumonia is higher for pediatric strains than the adult strains. For example, the penicillin resistance rate of strep pneumonia in Taiwan was more than 60%, but the penicillin resistance rate was about 20% for the adult strain. So this suggests that the more antibiotic may be given to children, and the overuse of antibiotic is one important factor driving the emergence of antibiotic resistance. Following the appearance of antibiotic-resistant pneumococcus, we have a big problem of increasing complicated infections. In Taiwan, the instance of severe pneumococcal pneumonia with pleural effusion, pleural empyema or necrotizing pneumonia increased dramatically in the late 1990s, coincide with the emergence of penicillin-resistant pneumococcus. This is also true for other Asian countries, including South Korea, China, and Vietnam. You can see that the overall instance of empyema and pleural effusion or severe pneumococcal pneumonia is increasing. And the major one responsible for this kind of severe pneumonia is pneumococcus. And antibiotic-resistant Staphylococcus aureus seem also increasing in recent years in many Asian countries. This is also true for otitis media. We think otitis media may not be a severe infection, but sometimes it may leave a sequel of persistent hearing loss. In the States, they noticed that after the emergence of antibiotic-resistant bacteria, including pneumococcus, the instance of mastocytitis is increasing in children younger than 2 years. But however, the instance of mastocytitis seems to be flattened for older children. This is also true in Taiwan. Now we have more and more children with severe otitis media and mastocytitis, and the increase in instance is also coincide with the emergence of antibiotic-resistant pneumococcus. How to control the emergence of antibiotic resistance? We must first know the factors related to antibiotic resistance. I think there are two factors, most important related to the emergence of antibiotic-resistant pneumococcus. One is antibiotic use, the other one, vaccination. And we know overuse of antibiotic is associated with increasing instance of antibiotic resistance. If we restrict the use of antibiotics, whether or not this kind of restriction may or may not reverse the trend of increasing antibiotic resistance, this is a somewhat controversial issue. And we can see that in this review article, it was said that the relationship between population level changes in antibody use and pneumococcal resistance are complex and may arise due to multiple resistance or other classes of antibiotics maintaining selection for multi-drug resistant strains. So it means that the antibody resistance genes may link together. If you restrict the use of one antibiotic, you cannot revert the antibiotic resistance because other kind of antibiotic still working and selecting for antibody-resistant bacteria. Here is one example. This study from the States shows that after the decrease of penicillin prescription, the instance of penicillin non-susceptible pneumococcal remained stable. The resistance rate did not decrease, and the penicillin resistance rate decreased only after the routine use of 7-valent pneumococcal conjugate vaccine in the States in the year 2000. This is also true for cotrimazole. The instance of cotrimazole resistance of pneumococcus remains stable after decreasing prescription for cotrimazole, and the resistance rate decreased only after routine vaccination of PCV7. So, the emergence of resistant pneumococcus is closely related to overuse or abuse of antibiotics, and restricting the use of antibiotics may or may not revert the increasing instance of antibiotic resistance. Another factor that may have major impact on the instance of antibiotic-resistant pneumococcal is the use of pneumococcal conjugate vaccine. It is because as shown by this study from China, we can see that the more prevalent the pneumococcal strain, the higher their antibody resistance rate. It is because these pneumococcus must be resistant to antibiotics to survive under the pressure of antibiotics. They must be resistant to antibiotics to become prevalent. And these prevalent serotypes are covered by our pneumococcal conjugate vaccine because they are more. So the pneumococcal vaccine contains most prevalent serotype and the most resistant pneumococcal strains. So when we give children routine vaccination by pneumococcal conjugate vaccine, the instance of penicillin-resistant pneumococcus decreased immediately because most of the prevalent and the most resistant strain had been covered by the vaccine. However, this is not the end of the story. We have a problem of serotype replacement after universal pneumococcal conjugate vaccination. We know that the nasopharyngeal carriage of pneumococcal decreased significantly for the vaccine included serotypes. But there seems to be some competition between different serotypes of pneumococcus. The non-vaccine serotype carriage rate increased in nearly all studies after a routine pneumococcal conjugate vaccination. This phenomenon is called serotype replacement. And several important serotypes had not been covered by initial 7-valent pneumococcal conjugate vaccine, including this one, 19A. 19A is a very famous and very notorious serotype. This serotype is highly resistant to many antibiotics, and this serotype is quite virulent. It is associated with invasive pneumococcal disease and parenchyma. And in several Asian countries, we can see that the instance of serotype 19A infection is increasing in many countries, including China, India, Korea, Malaysia, Sri Lanka, Taiwan. Taiwan from 0 to about something like 5%. And recently, before our routine vaccination by using PCV13, the percentage of serotype 19A in our invasive pneumococcal disease surveillance is over 50%. So this is the terrible serotypes. So we have to try to capture to the steps of serotype replacement. More and more non-vaccine serotype become replacement after routine vaccination. So we have to cover more serotype. It has been mentioned that there are more than 90 serotype of at least 90 serotype for pneumococcus. So we have to expand the serotype coverage by pneumococcal vaccine. So now we have 10-valent pneumococcal conjugate vaccine and 13-valent pneumococcal conjugate vaccine. Some experts are quite pessimistic about our future, because we anticipate that serotype replacement will continue to occur. And some years after the introduction of PCV, and some other serotype may emerge. And then we have to continue to try to capture to the steps of serotype. And this paper says that the pneumococcal conjugate vaccination alone may not be successful in controlling selection for resistance in pneumococcus. It is because when we use pneumococcal conjugate vaccine, 7-valent, 10-valent, 13-valent, we can decrease vaccine serotype. But there are still more than 80 serotypes waiting to emerge. The non-vaccine serotype will continue to emerge, and the overall antibiotic resistance rate of pneumococcal may remain stable in the future. It is technically almost impossible to make a 90-valent pneumococcal conjugate vaccine. It is very difficult. So our future is, we will fail in the future. Many experts may think that. However, when we know the phenomenon of capsule switching, we know that we found that this problem is in fact quite complicated. What is capsule switching? And by gene sequencing, we now know that some 19A at present is in fact 19F in the past. 19F is covered by PCV7, but 19A is not included in PCV7. So when you give children routine PCV7 vaccination, some 19F steal the gene from 19A. They steal the capsule. So it appears to be 19A by serotyping, but the backbone of this bacteria is still 19F, and it still have antibiotic resistant gene. So 19A become prevalent after PCV vaccination. It is not because of simple competition between different serotypes. The gene transfer among different pneumococci is now known to be a frequent phenomenon. So if you use vaccination to protect against the 19F, they will change the capsule and become a new one. So the present 19A serotypes has in fact many different ancestors, including 19F, serotype 4, and serotype 9V. They change the capsule to survive under the selection pressure induced by routine vaccination program. Such a phenomenon is called capsule switching or serotype switching. So I think this study is very important for us to know. And the capsule continues to switch. The problem is that every capsule is usable. Every capsule is associated with the same virulence. This study say this is not true. This study from the States suggests that the virulence of pneumococcus correlate with the thickness of the capsule. Only pneumococci with thick capsule can show resistance to neutrophil and then to be invasive. And only pneumococci with thick capsule can be associated with a high nasopharyngeal carrier rate in human. So if this observation is true, the usable capsule for pneumococci is limited because those thin capsule may not be so virulent as the thick capsule. So pneumococci can steal thin capsule in the future by serotype replacement. Now these pneumococci may be less virulent for human. So our future, it may not be a total darkness. And when we know the phenomenon of capsule switching, and the usable capsule for pneumococci may be limited, and our future may not be limited. So if the possibility of serotype replacement in the future is limited by the thickness of the capsule, the overall carriage rate of pneumococcus may be decreasing in the future. So if this is true, the vaccination alone may be at least helpful in controlling the selection for resistance in pneumococcus. And we will have a bright future with the help of pneumococcal vaccine. Thank you.